afternoon, everyone. Thank you for joining us today for the Diabetes Care Conundrum, Counting Carbs and Costs as part of the People of Color Living with Diabetes Second Annual Virtual Summit. With me today is my colleague, Alice Thomas. Alice, could you please introduce yourself?
Hi, everyone. My name is Alice Thomas. I am a registered dietitian and a nutrition consultant at St. Joseph's University Medical Center in Paterson, New Jersey, and I am also a board member of the Diabetes Leadership Council.
And I'm Erika Emerson. I'm Chief Policy Officer of the Diabetes Leadership Council. We are a 501c3 nonprofit patient advocacy organization advocating on behalf of all people with diabetes. So our objectives today are threefold. We're going to identify cost-related challenges to diabetes self-management, looking at some of the factors other than direct healthcare that get in the way of successful self-management of diabetes. We're going to look at how different types of insurance coverage influence the type of diabetes care that people receive. And finally, we'll leave you with some resources and solutions for both providers and patients to improve access to affordable diabetes care. Alice?
Okay, thank you, Erika. So let's begin with a brief overview of the effect of diabetes around the world. The information that you see on this slide is taken from the 2019 International Diabetes Atlas. Currently, the prevalence of diabetes is 9.3% of the world's population, which is approximately 463 million people around the world with both type 1 and type 2 diabetes. However, if of these 463 million, about 232 or almost 1 in 2 people don't realize that they have diabetes. And if you look at the various continents, you'll see that all are experiencing increases in diabetes cases, some more than others. So by 2045, the number of people with diabetes will be approximately 700 million, or almost 3/4 of a billion people. That's almost a 51% increase in less than 25 years. So diabetes was a pandemic long before COVID. So how has diabetes impacted the US? Right now, the United States ranks 3rd in the largest number of adults ages 20 through 79 with diabetes behind China and India. It ranks 3rd in the number of persons with undiagnosed diabetes and 2nd in persons over the age of 65 with diabetes. The economic cost of diabetes is just overwhelming. The total annual cost of healthcare in the US estimated to be about $760 billion. And the cost of diabetes is about $327 billion, which is about 43% of the total cost spent on healthcare every year. As I mentioned in the previous slide, almost half of the healthcare expenditures in the US is related to diabetes and its complications. The $327 billion can be broken down into $237 billion in direct medical costs and $90 billion in reduced productivity. So what is that reduced productivity? It's increased absenteeism, it's reduced productivity while at work, there's an inability to work because of the diabetes, or lost productive capacity because of early mortality. So when you look at the chart on the right, and you'll see that the breakdown of $237 billion, the largest expenditure is hospital inpatient care. The next largest, which is the gray area, is the amount spent on prescriptions for treating diabetes complications. The 3rd largest area is physician visits, and diabetes medications and supplies account for about 8% of that direct costs. So bottom line, more than 60% of the cost is being spent on complications and inpatient visits rather than on managing diabetes or on diabetes medications and supplies. Diabetes is basically about self-management, and it's not the easiest condition to manage because often the person with diabetes has to make frequent and sometimes minute-by-minute decisions or adjustments to their medication or their management. The result is higher costs than for most other medical conditions, and research from the American Diabetes Association has shown that persons with diabetes have 2.3 times the healthcare costs of people without diabetes. Also, we know that diabetes can and does affect many other parts of the body, including the eyes, heart, kidneys, and may result in lower limb amputations. In a Reuters article on August 12th, it stated that diabetes-related deaths in the US rose faster in 2020 than for any other disease among the leading causes of death. Since the topic of this summit is diversity, we have to mention how diabetes impacts communities of color because we know healthcare is not equitable. Take, for example, the African American community. There are more deaths, more complications, and more hospitalizations associated with diabetes, while at the same time, the types of care that is needed to decrease the risk of complications and mortality, such as flu shots or foot and eye exams or A1Cs being performed, are less likely to be ordered. So what are the tools needed in order for the person with diabetes to successfully manage their conditions? There are several, as you see on this slide. These include medications, medical devices such as meters, pumps, and CGMs, lancets, syringes, and needles. But they also need services, which includes diabetes self-management education, and that includes the services of a CDCES, or Certified Diabetes Care and Education Specialist, and the registered dietitian. So it is estimated that the average annual cost just for the tools needed for managing their diabetes is about $17,000. So the question is, does the person with diabetes have access to affordable healthcare so that they can get all the tools they need? That's a question that needs to be answered. So what are the challenges to successful diabetes management? As I mentioned before, diabetes is for the most part self-managed, and it is a 24-hour, 7-day-a-week, 365-day job. It takes discipline to repeat the same regimen every day, and let's face it, the person with diabetes does not get to take a day off in managing their condition. There are also other factors besides diet, physical activity, and medication that are involved in diabetes management. This slide is from Diatribe. It shows 42 factors, and there could be more, that affect diabetes management and also blood glucose levels. Factors such as sunburn that can increase blood glucose levels to dehydration, or something that you can't control, such as outside temperature. So when it's cold outside, this can increase a person's insulin requirements. Or on the other hand, if it's hot outside, blood vessels can dilate, which will increase insulin absorption and potentially lead to hypoglycemia. So let's talk about a case of a 40-year-old woman with diabetes. She has type 2. She comes into your office for an appointment and she tells you she hasn't been taking her insulin. So what questions would you ask her? Is she afraid of taking insulin? Many people are afraid of injecting themselves, especially if they were previously taking an oral medication. Does she think that by injecting insulin that it might cause diabetes complications? Maybe she had a grandma or an Uncle Bill or an Aunt Susie that almost towards the end of their lives, they were taking insulin and she's associating that with their deaths. Does she know how to take insulin? Maybe you want to review her techniques for administering insulin? Or would you ask her, can she afford the prescription that she was given? So for the remainder of the presentation, we're going to show how the cost of just one medication used in diabetes treatment, which is insulin, how it does affect successful diabetes management. We are seeing more and more of these headlines on TV and the internet and print. People are concerned about the high price of insulin, and the cost doesn't seem to be decreasing at all. They are asking why insulin costs so much in this country that people are actually crossing the border to Canada to purchase the same insulin at a much lower cost. So in August of this year, the CEOs of the 3 insulin manufacturers in the US, Lilly, Novo Nordisk, and Sanofi, were sent letters from the House Energy and Commerce Committee because of their concern that the price of insulin remains unacceptably high, and why the cost of insulin in the US is 10 times higher than the cost of insulin in 33 other countries. So what is the list price? The list price is the price that is set by the pharmaceutical manufacturer. It is the highest possible price a buyer will pay before any discounts are applied. Notice I didn't say who the buyer is. The net price, on the other hand, is the price the manufacturer received for their medications minus any rebates, discounts, and fees. So this explains why the net price could decline even as the list price continues to grow. So when you look at the example, the list price for insulin may be $334, but with the rebates and other factors, the net price may be $85. That's almost a savings of $250. So the question is, who gets the $250? So does everyone pay the same price for insulin? As you see with the slide, the answer is no. All these people who you see here may have been prescribed the same type and the same amount of insulin, but the price that the person pays may have a huge influence on whether the person fills the prescription or whether they may end up rationing the insulin or even using expired insulin. So take, for example, John, the first person, pays zero amount per month for his insulin. Chanel, on the other hand, pays $25 a month. Jeremy pays $360 a month. And poor Susan, to the far right, is paying $1,200 a month. So Erika is going to go into more detail about this. There are serious consequences for people having to ration, or as I mentioned in the last slide, having to use expired insulin. Unfortunately, it could lead to death. Each person on this slide had type 1 diabetes, and all of them passed away because they weren't able to afford their insulin. All of them were in their 20s. They died, again, having to ration their insulin, and they couldn't keep their blood glucose levels in control with a cheaper insulin. Some couldn't afford the high deductible in their insurance plans, so some of them stopped eating to take less insulin or skipped their insulin altogether. Some had to decide if they were going to pay rent or if they were going to pay for their insulin. Not taking insulin for someone with type 1 diabetes is literally a death sentence. And most of the people you see on this slide died from DKA or diabetic ketoacidosis, which is an extremely high blood glucose level. Some of them had aged off their parents' insurance plan, and the job that they had didn't pay or didn't have health insurance. So with that, I'll turn it over to Erika, who will discuss what are some of the causes to these challenges to successful diabetes management. Erika?
Thank you, Alice. And that's a difficult transition to make. We don't want to lose sight of the fact that when we're caring for people in the diabetes community, we need to pay attention to those who have insurance and those who don't. Obviously, having effective insurance is a necessary step to afford the care you need. But even when someone has insurance, we're now finding that it's important that they have the right type. There are types of insurance that are helpful for people who have diabetes. And then there are insurance types that actually can make it more challenging to manage the condition. We call this the insurance conundrum. Obviously, in the United States, as Alice mentioned earlier, we have a very complicated system of healthcare that drives up the cost of healthcare, including prescription drugs. And obviously that this is a system with some entrenched interests in it between insurers and PBMs, pharmacy benefit managers, manufacturers, payers like employers. We have all of these different stakeholders in the healthcare system, and the systems of coverage that they've created often get in the way of healthcare or the relationship between a patient and their healthcare team. So some of the access challenges we're going to see in sort of a structural or process sense are the role of rebates, which Alice referenced earlier, the impact of non-medical switching. We'll talk a little bit more about what that is. The impact of rising out-of-pocket costs on consumers, and the supply chain complexity. Now, each of those factors will vary depending on what type of insurance an individual has. Now, these are the major types of insurance most people in the United States have. On the public side, we have Medicare, Medicaid, and military. On the private or commercial side, most Americans actually get their health insurance from an employer, typically a large employer, but many small employers offer insurance as well. And we do have the individual insurance exchange at the state level. For conditions like diabetes, those plans really can be a lifesaver for a lot of those young people who are employed in jobs that don't offer insurance, or they might be managing multiple, say, gig work, working in the gig economy. In a state where insurance costs have been capped in the individual exchanges, that means that individual insurance might actually make a whole lot of financial sense and really be a lifesaver for young people with diabetes. And obviously, going into COVID, we had an increase in the uninsured rate in the United States in the last several months that has only gone up. So as the country looks to come out of this global pandemic, we do need to make sure that in states that have not expanded Medicaid or have not raised awareness about the availability of the special enrollment period and subsidized insurance in the individual market, we need to make sure that we're reaching out to those in the community to help them connect with affordable insurance and affordable care. Now, once a person has insurance, unfortunately, they have to deal with what we call the alphabet soup. There are HDHPs and PPOs and EPOs and HMOs. We'll talk about health literacy and insurance literacy and how important it is. But when a person has diabetes, it is really important to understand the type of plan that you're signing up for and how that can impact your access to care. One of the most dangerous plans for a person with diabetes to have is a high deductible health plan. By and large, those plans don't provide coverage until you've met a very high deductible, which means you could be paying out of pocket thousands of dollars before your coverage even kicks in. Now, as we've seen with the impact of rising list prices, that means a patient is effectively stuck paying inflated prices for essential care just to get their insurance to kick in. And this is insurance that they have paid for. When you pay for insurance, you expect to get the benefit of those network negotiated prices. And that's not always the case, particularly with prescription drugs. So PPOs, EPOs, HMOs, those are all types of networks where your insurance company basically tries to direct the providers who you can see or where you can receive care, ideally to get you the best price or the most value for your healthcare dollar. But again, depending on how that plan is structured, when you have diabetes, it really depends. So drug coverage. Why are people experiencing such high prescription drug costs? It's not just that prescription drug costs are really high in the United States. It's the fact that prescriptions are underinsured compared to other components of healthcare. As Alice mentioned earlier, right now, when we look at how much the nation is spending on diabetes care, we're spending much more on complications and hospitalization than we are on prevention, on making prescription drugs more affordable for the people who need them. So for every dollar spent on prescription drugs, the patient is paying 15 cents out of that dollar, whereas every dollar for hospital care, they're paying 3 cents. You would think in a value-based insurance market, that would be flipped. You would want to emphasize preventive care to reduce the costs or the incidence of those complications. We also see one of the most frustrating aspects of prescription drug coverage, patients not getting the benefit of discounted plan rates for their health care. When we look at something like hospitalization, there are no list prices that patients are exposed to. When you are insured and you go to the hospital, you get the plan discounted rate. When you go see a healthcare provider, you get the plan discounted rate. If you get a lab test, same. And these can be differences of hundreds of dollars, especially on the lab test side. For prescription drugs, the answer is maybe. Really, the type of plan you have and how the plan is structured determines if you get the benefit of the negotiated rates or if you are exposed to list prices. Now, for insulin, more so than a lot of other drugs in the marketplace, this spread between rebates and net price have continued to go up and up and up. As Alice had mentioned earlier, we have all of the factors in the healthcare marketplace that would be driving costs of insulin down. And when we look at the red bar, we see that that's exactly what has been taking place. As more insulins have become available, as competition has increased, those net costs are going down. But unfortunately, because of the warped incentives in the rebate system, the list prices are going up and up and up. So as patients who are exposed to list price need to pay for their insulin, if they're in a plan that doesn't pass through the rebates, they're getting exposed to very high prices. Now, moving on to non-medical switching. Non-medical switching, you can actually get some more information at diabetespac.org, is when a person with diabetes is stable on a care regimen and their insurance makes them switch. Typically, what that means is that there hasn't been a change in the product or how effective it is. It just means that the health plan has negotiated a lower price or a greater discount from that manufacturer. And this is a very familiar phenomenon with both people with diabetes and their healthcare providers, that this is when you go to fill something in January, and now suddenly you have to jump through extra hoops to get additional authorizations, or you pick up a prescription and it's something that you're accustomed to, something different than you're accustomed to. Again, these are for commercial reasons, not for medical ones. So as we've talked about how out-of-pocket costs are rising, unfortunately, and in this current system, it really puts the onus on the patient to be their best advocate. And by extension, healthcare providers can help connect their patients with assistance as well. If someone is struggling with access to insulin or other healthcare, there is help already available that does not take an act of Congress. Obviously, we would like the White House and Congress to act, but in the meantime, it's important to raise awareness of options that people can avail themselves of now. Now, you'll see more details of this on our website at diabetesleadership.org. But these, again, are just some simple steps that people can take themselves. If you see someone struggling, you can help them with. These are all downloadable, again, from our website. It's just making sure that we know that there are a number of patient assistance programs out there. We have the 340B system and networks of community healthcare providers, excuse me, and making sure that we're being very open and forthright and candid when someone is struggling with insulin costs. So we've talked a bit about insurance plan variability and the impact of the rebate system. So as we've seen the rebates increase and costs go down, that means that patients are benefiting from that rebate system if their health plan passes them through. If, for example, insulin is covered as preventive care for $0 per month, they are benefiting from those discounts. If they are in a plan, though, where those rebates are pocketed by the insurance company or the employer or the PBM, that's really money out of the patient's pocket. And this is how we find out how we got here. Supply chain complexity. At the Diabetes Leadership Council, we affectionately call this the hairball slide. This is a very simple depiction of our very complex system of paying for and providing prescription drugs. We could walk you through the whole thing, but I think if anything, on the right side, when we see different stakeholders in the system pointing fingers at each other, saying rising health costs are his fault, her fault, their fault, not me, it's because each stakeholder in this system makes money at every step, from the manufacturer to the patient. There are entrenched interests who take a little bit of that spread between list price and net price. So what can that mean for patients? It means per vial of insulin, instead of paying no dollars or say $85, the net price for a vial of insulin, they're paying an inflated price of $334. Those are actually actual numbers from one of our colleagues who is in an insurance plan that has full rebate pass-through. So real prices. There are patients being charged $334 for something that costs their health plan $85. So I know healthcare providers often talk about health literacy. At the Diabetes Leadership Council, we talk about health insurance literacy. And we work with a lot of our partners like College Diabetes Network, JDRF, Diatribe, and others to make sure that people with diabetes know how to choose and then use the right health plan. Again, we say watch out for high deductible health plans because they will expose you to very high costs at the outset, instead of spreading it out over the year so it's more affordable and easier to budget for. And doing the math. If you are fortunate enough to have employer-provided health coverage, you will be presented with different plans to choose from, and you really need to use the healthcare calculators, talk to HR departments to make sure that you're choosing the right health plan for you and your family. So, with that Debbie Downer of a presentation about how complicated our system is and how costs keep going up and up and up, we wanted to leave you with some tangible steps and resources that are available today. Alice?
Thank you, Erika. Now, we really don't want to leave this presentation on a low note or a sour note. So we believe there are global solutions that can be used to help our patients and clients achieve success in their diabetes management. And you see on this slide. So let's take the first one, the first dollar coverage for insulin. If you remember, this is the type of insurance where there is no deductible or copay. So insulin would be exempted from those paying a high deductible health plan. The next is the no or low predictable cost sharing for diabetes management, education, and tools. With this, the insurer would provide coverage for diabetes self-management education with little or no cost sharing to the patient. So research has shown that diabetes self-management education actually decreases cost and is cost effective. Also, out-of-pocket costs would be at the point of sale, which would be at the pharmacy, because the out-of-pocket costs, the more people have to pay these particular costs, the higher the incidence of lower adherence and the worse health outcomes. So that would entail manufacturers sharing their rebates with the consumer. The next one is using evidence-based practice rather than step therapy or prior authorization. Step therapy is when an insurance company requires a person to try one or more preferred drugs before coverage for a more expensive alternative is approved. Prior authorization requires a review of certain medications before an insurance company plan will cover them. However, both of these are fail-first policies and neither is evidence-based. So why should a patient's health be possibly put into jeopardy by being subjected to potentially adverse effects? The next is coverage of medically necessary prescriptions. All U.S. health plans, including Medicare and Medicaid, should cover medically necessary prescription medications to treat diabetes, its complications, and comorbidities. The next, Erika mentioned this, insurance companies should just stop the practice of non-medical switching because it's not a health-based issue, it's a financial issue. And lastly, it's transitioning from a fee-for-service to a value-based healthcare system. So it's shifting our healthcare system away from what it is now, a fee-for-service that pays for quantity of care, to a system that pays for value or quality of care, because it has the potential to improve diabetes outcomes if it is done effectively.
Now we have a number of resources available here. These are just suggestions. You'll find a more comprehensive set of links and information and resources on our website, diabetesleadership.org. But we've captured here really a plethora of resources that are available to help with insulin costs, as well as access to diabetes supplies, CGM supplies, things of that nature. I give serious kudos to the diabetes community over the last 2 years at least. The number of resources available has continued to increase. So at this point, those resources are available. We just need to make sure that people know about them. Both people with diabetes, their families, their support networks, and their healthcare teams. These resources are available. Unfortunately, we would love for every person with diabetes not to have to access an outside source for assistance, but until we have achieved a universal coverage in whatever form that takes, we don't want any more people to be in a position of rationing their insulin. There are assistance programs available today that include same-day vouchers. So if someone is in an emergency situation, they can call a number, get the voucher, take it into their pharmacy the same day to get an emergency fill. There are state-based programs that make sure that pharmacies can dispense emergency supplies. So we want to make sure people are aware of those. And as always, we have the network of 340B providers, community health centers, who are able to purchase insulin for no or low cost. And we want to make sure that they're passing along that no and low cost insulin to the patients who need them. That's why our community health centers are there. They're there to take care of their communities, including the diabetes community. And this is the most exciting part. Not only are there assistance programs to connect people with access to affordable insulin and others, there are a lot of organizations involved on the advocacy front, encouraging state and federal policymakers to pay attention and to address the community's needs. Again, you'll find a lot of these resources available or linked from our website at diabetesleadership.org. I invite you to go visit, poke around, and you'll see lots of connections out to our partners in the diabetes community. You also will find on the website, available for download, the consensus statement on U.S. healthcare reform for people with diabetes. So DLC was pleased to serve as the the convener, the great convener of an effort of 12 national diabetes organizations to reach consensus on what changes need to take place in our healthcare system, Medicare, Medicaid, and commercial, to make sure that people with diabetes have access to the care they need. We know policymakers are going to be taking a look at healthcare reform. We wanted to give them a roadmap with a diabetes patient-centered lens. We also want to make sure that patients and providers know that advocacy is an iterative process. We always talk about lather, rinse, repeat, those instructions that are on shampoo bottles. There are lots of ways to engage in advocacy. The Diabetes Patient Advocacy Coalition is one of our formal partners. They have lots of click advocacy, lots of learning opportunities, brown bag sessions, state-based forums, Hill Day visits. So you can follow them at Diabetes PAC. You can follow us at Diabetes Leaders on Twitter. But again, lather, rinse, repeat. Find these opportunities to engage in the issues that matter to you and do it again and again and again. So thank you again for joining us today at the virtual summit. We're going to leave you with some takeaway steps. Again, if you want more details, please visit our website, diabetesleadership.org, or our partner, diabetespac.org. But our takeaway steps are this: ask, refer, and advocate. If you're a healthcare provider, talk to your patients about their medication taking. Make sure that they are able to afford them, they can get their prescriptions filled, and they're getting the care that they've been prescribed. Refer them to possible assistance programs, to 340B providers. Again, those resources are out there. We need to make sure that we are helping people with diabetes connect to the affordable care they need, and advocate, whether it's through DPAC, JDRF, ADA. There are a number of active organizations in the diabetes advocacy space and opportunities to advocate. So we encourage you to have that dialogue, take a look at your care practices or current processes of care, understand where diabetes costs are a barrier to self-management, be familiar with the resources available, communicate, and advocate. So thank you again for joining us today. If you have any questions, we encourage you to contact us via email at contact@diabetesleadership.org.